Okay, just to talk a little bit about low birth weight and prematurity. Leading cause of neonatal mortality and handicaps in infants. Okay, most very low birth weight, and that's less than 1,000 grams. Right, infants are premature rather than just small for gestational age. Right, because you can have infants delivered who are full term, 37 weeks, but very, very low birth weight for their size. So it's a little bit different. So, depending on how much the baby weighs, remember 454 grams is a pound. Okay. So 20% of 500 to 600 grammers survive. And we're just talking about survival, not with debilities. 85 to 90% of 1,250 to 1,500 grammers survive. That's actually considered a large premature at this point. And remember, very few born at 22 weeks or less survive. Most of the severely disabled patients that I have now who were premature, so premature of about 24 weeks, which, again, can be in the 500 gram range. There's greater than 95% survival associated with gestations of 30 weeks or more. And the mortality from prematurity results from conditions associated with immature organs. So RDS means respiratory distress syndrome, the sequelae of which is chronic lung disease, the equivalent of chronic lung disease in adults. We used to call it bronchopulmonary dysplasia. Now we call it chronic pulmonary disease. IVH, intraventricular hemorrhages, are very, very common in young premature infants because of immaturity of the structural parts of the brain. And necrotizing enterocolitis, are you familiar with this? Maybe you know this from adults, is actually necrosis of the bowel wall, again, due to immaturity of the immunologic system. Really. Okay, to talk a little bit about sudden infant death syndrome. It certainly was the most common cause of death in infants less than a year. I'd like to see how that changes as the years go by, because it will change. It's a diagnosis of exclusion. So having seen many of these before the American Academy of Pediatric recommendation, the typical presentation of a baby who died from SIDS is that they come into the emergency room at 6, 7, 8 o'clock in the morning. The history was that everything was fine the night before. It's a normal baby, no conditions, no defects. Put the baby to sleep and go in early in the morning to check on the baby, and the baby's not breathing and unresponsive. Okay. So the peak incident occurs at 2 to 4 months of age. And again, 90% occur in infants less than 6 months. I've never seen one in a baby older than 6 months. And the risk factors are sleep position, soft bedding, and there's an association with cigarette smoke. And then there was, of course, the Back to Sleep campaign, where the safest position and that least associated with SIDS was found to be if you put your baby on the back. And about 1 to 5% of deaths initially diagnosed as SIDS turn out to be a result of abuse or suffocation. And this accounts for the vast majority of unexplained, unexpected infant deaths. And in the 1 to 5 year age group, the most common cause of death is unintentional injuries, including motor vehicle accidents, drownings. We don't see that much of it in New York, but places where there are lots of swimming pools and that there's, drowning is quite a significant cause of mortality in this age group. Fire, burns, airway obstruction injuries, motor vehicle pedestrian injuries. Okay. Then there's congenital anomalies. We talked a little bit about that earlier. Finally, you start seeing malignant neoplasms. The most common cause in patients less than 20 years of age are the leukemias and the CNS malignancies, compared to adults, where the most common cause are lung, breast, and prostate cancer. And then finally, you have the whole category of child abuse, intentional injuries, homicide. Okay. Finally, where do children die? Okay. If you look at all comers, all diagnoses, about 56% die in the inpatient, 16% in outpatients, a small percentage are dead on arrival at the hospital, and 11% die at home. And 11% they couldn't figure out where they actually died, and very, very small percentage die in a nursing home if you compare it to our adult population. And this is quite a number of years ago, the mortality data. And what about patients who have cancer? Where do these children die? Well, a much higher percentage, 36%, die at home. Again, 58%, about the same number in hospital inpatient. So it's almost tripled if you're taken care of by a pediatric oncologist, where this may be something recognized, right? Okay. So what about the implications of the patterns of childhood death? So it's a very diverse group. The children who died, their families are a very diverse group. Unintentional and intentional injuries make an important contribution to death in childhood. An array of rare fatal disorders collectively generate a significant impact on the death rate. Many important causes of death in childhood may be linked to socioeconomic disparities. Poor prenatal care and neural tube defects, and just poor medical care in general in the child who has a congenital anomaly or metabolic anomaly. Hospitals play an important part in the care of children who die of complex conditions. We see that 58% of pediatric patients do die in hospitals. And no single protocol for palliative care fits the needs of children and their families. Okay, if we look at dying trajectories for children, they're very similar to adults. We have the sudden unexpected death, like a SIDS death, and accidents or injury. Lethal congenital anomalies. It's a very rapid trajectory. Potentially curable disease may have plateaus of stability, but eventually, slowly, the patient declines. And then the last one is something like asthma, where you have a very slow decline, or rather chronic lung disease in children is a good example of the last one.